Good afternoon, everyone. Thanks for joining. We will be starting momentarily. If my panelists can let me know if they see my slide in full screen. Perfect, thank you. Again, thank you participants for joining. We are going to give it one more minute before we get started, just being mindful of everybody's time. So thank you for joining today. All right, we will go ahead and get started. Thank you all so much for joining today. My name is Sulema Salgado, and I'll be the facilitator for today's presentation. Wanted to share a couple slides with you, a little bit about us and the National Telehealth Resource Center, along with the Southeastern Telehealth Resource Center. We're a collaboration of 12 regional and 2 national telehealth resource centers, TRCs. As federally funded programs, the TRCs assist with policy and reimbursement, business models, and getting started in telehealth, equipment selection, best practices, practice guidelines, program development, webinars, and much more. So we are delighted to have you guys join us today for today's special presentation. Just to give you an overview of our Southeastern Telehealth Resource Center team, you will see here with us on the slides our principal investigator, Rena Brewer, Lloyd Sermons, our director, who's on the call today, Mark Boyd, our director of programs and digital transformation, also does a lot of work in the U.S. Virgin Islands, and then myself, Sulema Salgado, as the Director of Programs for Puerto Rico, but also focusing efforts on Georgia and the other coverage areas in our TRC. Our Southeastern Telehealth Resource Center covers Alabama, Florida, Georgia, South Carolina, Puerto Rico, and the U.S. Virgin Islands. So we're delighted and thankful for all of you joining us today and sharing with us this awesome presentation. I will allow our first presenter to kind of kick you off and give you a little bit of background about the presentation and go from there. So Dr. Carr, if you want to go ahead and get started.
Absolutely. Can you hear me okay?
We can, perfectly.
Great. And can you see the slides?
Yes, we can.
Great. Well, I'll go ahead and kick us off, and I'm going to continue to advance the slides as the other presenters and panelists get started on their slides. I'll be kicking us off first with the Emory Rural Tele EMS Network, and we are a now statewide footprint of telehealth equipment in the back of ambulances that's part of the Southern Regional Disaster Response Center, or system. So I'm going to talk first about that and then hand it off to Dr. Ross to talk about tele-observation, Dr. Lyon to talk about telecritical care services, and then Dr. Isaacoff's going to wrap it up with giving more of a global view of the SRDRS, and then hopefully we have got a little time for Q&A. So as I said, Michael Carr, I'm an emergency physician at Emory University Hospital, and I work clinically also at the Atlanta VA. But as part of my pre-hospital and disaster medicine role, I'm the director of the Emory Rural Tele EMS Network. We are a grant funded by HRSA, Health Resources and Services Administration. We got a startup grant in 2020 to build out this network. And I'm required to say that the contents that I'm going to share with you doesn't necessarily represent the views of the US government or an endorsement by the US government. So there's the disclosure slide, but I have no other financial conflicts of interest to disclose. I'm going to really just summarize our program with just 5 big things. And the 5 takeaways I do want to share with you are why, about how ERTEMS, the Emory Rural Tele-EMS Network, got started. I want to give some insight to our software equipment and our connectivity solutions. Sustainability is a major focus of our project, and I'm going to glance over that and hopefully share a little bit more about our partnership with the Southern Regional Disaster Response System, and how that will be part of our sustainability plan moving forward. And finally, Dr. Isaacoff will highlight more on the vision for SRDRS, but we should be in good shape. All right. So first, our why. And so, I have to always start with the story of how I got started with ERTEMS. I actually had COVID early on in March 2020 and had opportunity to be locked away in a room. And as it turns out, was productive in putting together a grant proposal. So that's the silver lining of the pandemic for me. But in that, really developed my passion and interest in the rural disparity. So I'm going to present kind of our challenges and successes as the pathway from getting started from that very room, and many on this call actually being involved in early conversations of this concept and how we might be able to build out a tele-EMS network that could support a rural disparity. The rural disparity, when I say that, I'm referring, of course, to the access to healthcare in rural areas throughout the United States. As you may know, about 97% of the geographical United States is considered a rural designation, whereas about only 20% of the US population lives in a rural area. So, as it turns out, the farther away you are from a healthcare system, the harder it is to access. And especially in the setting of critical time-sensitive conditions, it's really, it really reduces worsens the morbidity mortality in time-sensitive conditions like STEMI, stroke, and trauma, as an example. So rural hospital closures is certainly not the primary reason for this, but it is certainly a large contributor. Since 2005, we've had this many rural hospital closures, and the yellow dots represent rural hospital closures since 2020. So seemingly as a direct result of the pandemic. So if you can imagine yourself in a rural county of Georgia with a heart attack or a stroke, all of a sudden an ambulance shows up to your house after calling 911, and you've got probably on average a 30 to 45-minute ride in some of these counties just to get to the closest hospital. So that's kind of where we start with our workflow. If you picture yourself as a rural paramedic in the back of an ambulance, you can call in over a virtual telehealth equipment that we've installed in the back of the ambulance and speak to an emergency physician. And that physician can provide treatment guidance or clinical guidance and oversight. But probably equally as important, they are facilitating that patient's care before their arrival to often a small rural hospital or a critical access hospital. So the example of a stroke, they can call in and say, you've got a stroke patient about 20 minutes out. Go ahead and clear your CT scanner table so that we can get the scan done immediately upon their arrival. I'm going to give a comprehensive report to the charge nurse and or the attending physician on call. Oh, and by the way, give me the number for your on-call neurologist. I can give them the story to start, speeding up the care of this patient. So those micro steps are really what's going to contribute to the overall improved flow of that patient's hospital stay. Here's our current footprint, and I'll show you some photos of what the equipment setup looks like in the back of the ambulance. But our current footprint of ambulances that are deployed, meaning they have equipment in them, and we are at least in the process of training. And we anticipate over the next year to add a few more counties to broaden our footprint. The conversations are currently in process, and we anticipate that we can deploy equipment in the next few months and hopefully have them up and running. And what this means is these crews will have the capability to call in, as I demonstrated in that workflow diagram, to get on, up-to-date treatment guidance. The future really of our plan, and I'll mention it now, is we've built this model across the state of Georgia, and that model, gained some attention of the Southern Regional Disaster Response System that is funded by ASPR, and that's the primary focus of this webinar today. But ultimately, the plan is to replicate or act as a model of our system across the Southeast United States. So in particular, HHS Region 4, which is highlighted in the blue down here on the map. Our software, equipment, and connectivity, when we went into this, I want to point out that we had planned about 30 ambulances over the 4-year grant period. We have since surpassed that 30 ambulance goal, and we continue to expand, really trying to focus on refining our process and expand at the same time. We developed a software relationship with SWIMED, which has recently partnered with Zoll, but SWIMED specializes at delivering telehealth and virtual solutions in rural and austere environments. So their software actually is designed to maintain a call in a poorly connected environment. We use a DT research tablet, which I'll show you a photo of. It's durable, antimicrobial. It's drop tested, but as I always say, some of our crews figure out how to break it despite its indestructibility. So we also have a pan-tilt zoom camera up in the ceiling of the ambulance and a Yamaha speaker mounted on the wall. That's really important for noise cancellation, especially while the ambulance is going down the road, lights and sirens. We can hear everything and they can hear us just fine. And then we've primarily used Zoll X series monitors. We have the capability to integrate via Bluetooth the biometric data from that monitor, and it connects it directly with our telehealth interface. So here's our DT research tablet. As I mentioned, SWIMED is our software vendor. We have the tablet mounted on a RAM mount here, but here's the pan-tilt zoom camera up in the top of the ambulance. This camera has remarkable clarity. We were testing it out, and we could put a Mountain Dew can up on the front console of the ambulance and zoom in and read the nutritional information. So that clarity provides the capability to do a fairly comprehensive physical exam. And even in the setting of a neurological exam, we can zoom the camera in on the patient's face, and the paramedic can shine a light in their eyes. We can actually see the pupils constrict. So there's the tablet mounted in the RAM mount. We can fold that up out of the way as well. And I mentioned Zoll X series monitors, our primary integration. We're working on connecting with other monitor systems as well. And that's what our interface looks like. We have our vital signs displayed on the right, and we can represent them graphically over time on the bottom and the duration of the call. So I'll wrap up with this, just saying that, our primary connectivity solution is cellular. There are limitations in rural areas. As it turns out, our antennas in the back of the ambulance can't see the cell tower that well, but by ramping up the gain or the wattage of that antenna, we do see some potential capability to install these high gain or high wattage antennas on the top of the ambulance to improve the capability of that antenna to see the cellular tower. We are considering Starlink or mobile satellite connectivity via Starlink. This is, I think, more of a future look for us, as satellite is going to be a really key component of our connectivity in the future, especially where poorly connected, cellularly connected areas of the state are just really, unfortunately, having a difficult time with connectivity. Real quick, just want to highlight our sustainability plan. We started with the Department of Emergency Medicine at Emory University using a dual service model. So this is a kind of risk mitigation for our department. We don't have to fund a dedicated physician to cover these calls. In other words, our physicians are already performing tele-triage and tele-observation work, which Mike Ross will highlight after this. But those physicians can actually pivot their workflow away from that tele-observation rounding call and answer an EMS call if needed. So that's really a mitigation strategy for our department that so far has been pretty successful. And there's a picture of me working a tele-observation shift. Sorry for the goofy face. On the right here, I'm able to be doing one workflow, and if I get a call from an EMS crew, I can pivot over to the left there and speak with them and get a little bit more time. So, just our sustainability, that's part of our risk mitigation, but long term, we want to try to keep this program around, right? These grant funded programs tend to do great, and then all of a sudden the grant funding runs out and they disappear because they're not funded. So with that, HRSA has charged us to come up with a sustainability plan, which I'll highlight here briefly. Fee for service is part of this. In other words, we are coding and billing out the charts as an emergency physician visit. And that's really our compliance and legal team at Emory thought that was necessary, as this is scope of work for an emergency physician. That being said, fee-for-service model is not a primary way that we can sustain this network for obvious reasons. If you think about the rural patient as a whole being or underinsured, it's really not something that we can rely on. For one, as one example. Multi-use, we have this network, and I think that over time, we're going to see it used in many ways outside of what I already described. For example, low acuity treat and release, screening of involuntary patients as an example, trying to think of outside the box and many ways to use the network, you're more likely to keep it around. Subscription-based model that hopefully one day will be state funded or regionally funded is a goal. In other words, trying to figure out how to get state funding to support rural EMS agencies to basically buy into the model to sustain it. In no way do we expect that this is going to be a revenue stream for Emory, but really we don't want to be negative, right? Anytime you want to keep this programs like this alive, you have to make sure you're at least breaking even. And finally, philanthropy. So there are foundations that have publicly said they want to focus on the rural disparity. So that's a focus of trying to find foundations that may be able to support our network. I'm going to kind of glance over this because Dr. Isakov's going to talk more about our integration with SRDRS, but the long-term vision and our SRDRS integration is a key first step to our sustainability. And really, as we picture this model that I've already described, the goal here is to plug into a large tertiary medical center where we have access to subject matter experts that can be pivoted from this day-to-day use network to support a local disaster where there's a need for a rapid access to subject matter expertise, like toxicologists or burn surgeons as an example. So I'm going to wrap it up there and hand off to Mike Ross, but I just wanted to give the opportunity to snapshot this QR. If you want more information about ERTEMS, there's a great informational video that hopefully will summarize our program. And with that, I think I'm right at 15 minutes. So I'm going to go ahead and hand off to Mike Ross, and I believe I'm going to go ahead and advance the slides here. So let me just get past my summary slide, and Mike Ross, just tell me when you need me to advance.
Excellent. Excellent. Thank you, Dr. Carr. It's an honor to share with you our experience where telemedicine or virtual care meets hospital observation services, and that in turn integrates with disaster preparedness, what I would call a sustainable win-win. Next. In the next few minutes, we'll basically cover a background on what it is, what works and what doesn't when we talk about teleobservation. I'll describe the teleobservation sustainable model that we have been practicing and the evidence behind it. And we'll wrap up with disaster preparedness and what I would call a sustainable win-win. And by the way, the manual that I'll describe it's a link in the website there. Next. Okay, so before anytime I talk about observation services or observation medicine, there's a lot of confusion in terms. And that's because observation is both a verb, a noun, and an adjective. And what I mean is there are observation patients in a hospital in the emergency department. And these are what I call 6 to 24-hour patients that need more than 6 hours of care in the emergency department, but less than 24 hours of care if managed actively. This is a distinct and separate population from emergency patients or inpatients, which leads us to the next term, which is observation services, which is really largely a payer definition, which really at its core, the payers define observation services as management to determine the need for inpatient admission. That is what an observation patient is. They're outpatients. And interestingly, notably, they represent between 20 and 35% of all patients staying in any given hospital. So it's a sizable part of hospital operations, which leads us to the setting, which is really defined by two variables. One is the use of observation protocols, and the other is the use of a dedicated emergency department observation unit. So if you have a protocol-driven dedicated observation unit, that's a type 1 setting that has the highest level of evidence. On the other hand, no protocol, no unit, that's a type 4 setting. Notably, 2/3 of hospitals in the US do not have an observation unit. And in those hospitals, observation patients can often languish for days and days instead of hours, being managed to see if they need to be admitted. Next slide. Now, just a quick overview there. To review the evidence behind the type 1 setting, there have, over the last couple of decades, been 9 prospective randomized controlled trials, the highest level research evidence, these trials have all shown favorable outcomes in a type 1 setting relative to traditional inpatient care for conditions such as syncope, chest pain, atrial fibrillation, TIA, asthma, with outcomes including things like lower admission rate, lower cost, lower length of stay, better clinical outcomes, less diagnostic uncertainty, et cetera. There have been hundreds of observational studies. So there's a really large body of evidence supporting this setting in terms of patient outcomes in hospital care. Next slide. So to kind of help get your head around what I'm talking about, and let me give the tale of 3 hospitals, as I would call it. And that is basically what works and what doesn't. Next slide. So scenario A is a hospital, a common hospital, where observation patients come through the ED and they're admitted to a bed anywhere in the hospital. And that's indicated in this graphic with the blue beds. They're peppered everywhere. And I'll use very representative figures. Their length of stay will be an average about 33 to 44 hours. Their cost, not the charges, but the actual cost of taking care of them, will be about $1,978. Next slide. Now, if you pull those patients out of the bed anywhere and put them in a designated floor and use protocols, you may decrease the length of stay a bit. And by doing so, you may bring it down to, say, 28 hours. And you may decrease their cost to, say, $1,800. And in decreasing their length of stay, you will have effectively opened inpatient beds, indicated by the pink beds in this slide. Next slide. However, what you're doing is you're occupying inpatient beds with a group of patients that are really outpatients. In the hospital C scenario, you can actually take those patients and pull them completely out of an inpatient bed and put them in an emergency department observation unit and not even occupy an inpatient bed. And in doing so, the length of stay actually will come down further to 17 hours. The cost per case will come down to $1,342, but you will have opened inpatient beds by never even occupying those beds. Next slide. Now, if this makes sense, what we can do is take these 3 scenarios and basically run the math. Take an imaginary hospital that has, we'll say, again, representative figures, 3,000 observation visits per year, and subtract the cost per case or the impact of managing patients in hospital C, which is a type 1 setting, versus hospital A, which is a type 4 setting. And if you run the math out, which I've done for you here, for the difference in cost, the cost reduction for hospital C, for the type 1 setting, they'll save $1.9 million per year by doing that. If you total up the number of hours saved and divide by 24, that's called a bed day. The bed days saved, the total bed days saved would be 4,125 bed days. Now, if it happens to be a hospital that is running at a high occupancy and they can backfill with new patients, that's actually new revenue. It's called revenue enhancement. The contribution margin of a bed day is usually about $1,000 per bed day. So that means that they would bring in $4.25 million of new revenue by backfilling those now open beds. The net impact, cost reduction, and revenue enhancement, two completely different economic impacts. The net impact is about $6 million per year. Not bad for a day's work. Next slide. Now, are these purely rhetorical figures? No. And here I'll share Emory's data for Emory Midtown, Emory Johns Creek, Emory University Hospital, and Emory St. Joseph's Hospital. All hospitals have an observation unit, and they have, which we call a clinical decision unit or CDU. And that's one setting. The other setting is an inpatient bed anywhere in the hospital, a type 4 setting called a non-observation unit or no-use setting. That's the inpatient setting. And here again, you can see the length of stays are very representative of what I was showing, 17, 18 hours in the type 1 setting, 33, 36 hours in the type 4 setting, cost per cases. And again, if you run that math, and on an annualized basis, on an annual basis, the health system saved $24.8 million. And those 4 type 1 units opened 10,526 bed days. Now, this isn't just somebody driving a pink Porsche from a lot of money. What this means is that patients that need a heart transplant, patients that need a cancer therapy, the hospital may need to buy new state-of-the-art MRI or robotic equipment. It means that important resources are available to the patients really needing them, which will become relevant in the setting of a disaster. Next slide. Now, is this just to show that this is sustainable? I have 3 graphs and I've graphed out the census by setting. The blue line is the type 1, the CDU. The orange line is the no-U, the type 4 setting. And you can see that 2/3 of patients are managed in the type 1 setting. The difference in length of stay per case is about 20, 24 hours per case. Again, blue line is the CDU, orange line is the no-U. So there's a consistent roughly 20 to 25 hour difference in length of stay. And the cost per case difference consistently is about $1,000 to $1,500 per case difference in cost. Next slide. So really, for hospitals, this is great. It lowers costs, decreases length of stay, improves admit rates, improves inpatient bed availability. It hasn't always worked well for physicians, and it's largely driven by a billing model, the physician's financial billing model of 1 versus 2 groups, and the need for a critical number of beds. Next slide. Now this, without getting too deep in the details, this was shown in a paper that we published a few years ago, where if you have what's called the 1 service model, no matter how many beds you have, the cost of staffing that model compared with the revenue brought in by billing for professional services was always in a net negative cash flow state. Whereas if the physician was able to bill the same as if we were admitting to surgery or medicine, where the ED would bill for their work and the observation team or observationists would bill for their work. And that model, which a lot of academic medical centers have adopted, it works, but you have to have a threshold of at least about 20 beds. The break-even point where you start to see positive cash flow happens at 20 beds. Next slide. Now, a lot of hospitals don't have 20 bed, the ability to support a 20-bed unit. So it occurred to me that this is where telemedicine meets observation medicine, that by combining 2 or 3 units, we could meet that 20-bed threshold and support an observationist service. And it also occurred to me that telemedicine's been described for clinic visits, critical care visits, emergency visits, but really nobody had looked at the relevance of a different cognitive service, think something that you do with your head, not with your hands. There had been really no research in the observation realm. So next slide. So we launched kind of a full spectrum of observation services after the pandemic began. We were dabbling in tele-observation medicine before, but when the pandemic launched, we not only launched for tele-observation, but we launched the tele-EMS that Dr. Carr described, a direct-to-consumer nurse call line, telemedicine at our triage area, but I'll focus on the tele-CDU piece. Next slide. So what we did and this is a list of our, we now have 6 type 1 units within Emory Healthcare. We took two of the higher volume units, Emory Midtown and Emory University Hospital. With it, one had 16 beds, the other had 13 beds, and we combined those 2 units, giving us 29 beds and 8,713 patients per year. We're now working on applying this model to 2 additional hospitals to give a 22-bed setting. Next slide. And basically the way it works is the physician comes in to work or sets up their workstation. They have a 2-monitor setup. The APP, the nurse practitioner, connects to their telemedicine rounding device. At first, we made our own equipment, and then we moved to a proprietary AMO equipment, but you can make your own device if you so choose. And we would round at the computer on all the patients in the unit, and then we would round, the APP would round roll the cart into the room and would round at bedside from room to room. And then at the end, the physician would take 4 patients from each side, a total of 8 patients, and they would co-manage the unit together for the day. Next slide. Now, in doing this, we realized that we were doing something different. So we studied whether it was non-inferior. We did a diff and diff analysis. And what we found is that by rounding virtually compared to rounding in person, there was no difference in the length of stay, the inpatient admit rate, or the total direct costs, or the adverse events. That convinced us that what we were doing had no negative impact on care. Next slide. This gives more detail where we combine hospital A and hospital B for our both pre and post intervention period. And we had a control hospital, hospital C, that didn't do telerounding. And by looking at differences in those outcomes, we found that there's no difference in that for all the things that we could measure in a very large study sample in care. Next slide. We've then gone on to what I call the superiority study, where we're combining the care over 24 consecutive months, over 2 years, at the hospitals that did tele-observation, and to give a sample of 31,000 patients, comparing the no-you patients and the tele-obs patients. And to cut to the chase, we found that over those 2 years, we saved the hospitals $52 million, and we saved the health system 17,514 bed days. Big impact on resource use. Next slide. So we know that it works. Our virtual rounding is non-inferior. We believe it's superior, and it addresses a lot of things with the single service model that I described. It allows us to cover tele-EMS calls. It allows us to create a bigger, more sustainable telemedicine footprint as we grow the service. It also has helped in disaster preparedness. Next slide. You know, in my career, I've seen 6 examples of observation units being involved in managing a disaster. 2 inhalational disasters, 1 epidemic, 1 pandemic, 1 environmental disaster, and as I guess you could say 2, because 1 was when the power grid went out in the entire Midwest. In all cases, just as the emergency department serves as the safety net of the health system, the observation unit serves as a safety net of the emergency department. And when just as observation units help hospitals, next slide, helps hospitals with resource use, especially limited resource use, in a disaster, telemedicine and observation medicine can be leveraged to help a hospital with disaster preparedness. Number 1, it helps support daily use of telemedicine equipment and creates a workflow that can be immediately deployed. Number 2, we're developing observation protocols for the unique chemical, biological, radiation, nuclear, explosive, CBRNE disasters that happen for these 6 to 24-hour patients. Number 3, it provides immediate subject matter expertise for things that emergency physicians may not treat every day: radiation, chemical, biological. Number 4, it does a wonderful job of providing flexible staffing, both to manage the observation patients or any patients in a disaster. So having that working presence before the disaster provides a much more flexible staffing pool. And number 5, it preserves scarce resources that are so needed during a disaster, such as PPE or inpatient beds. Next slide. Okay, and with that, I'll pass the mic on to our next speaker. Dr.
Hey,
Lyon.
everybody, I'm Matt Lyon. Thanks for letting me talk today. I'm the director for the MCG Center for Telehealth. And what I wanted to talk about today was our Rural Hospital Virtual Care Network. Next slide. As Dr. Carr said, I have a lot of passion for rural disparity. And so his philosophy and my philosophy when it comes to working with rural communities really combines well. Like the Emory model, we started off with grant funding, but we're now self-sustained. So this program is continuing now without grant funding. So the why of why we have a rural community hospital outreach is if you look at the rural community hospital, they have a lot of things working against them. Next slide. And, you know, in a rural community, you have less population, so you have a lot less economic resources. And what that means is that you often run into situations where you have less healthcare providers, whether it's the physicians or whether it's nurses or respiratory therapists. And over time, you know, when you have less and less resources, you often have poor outcomes. And that's what we see in our rural communities. And then people start bypassing our rural community hospitals and go into cities. Next slide. And for when I look at this, you know, that leads to what I call the negative revenue cycle, which is, you know, when you lose confidence in your rural community hospital, you end up either bypassing them when you have an emergency, and that blends with what Dr. Carr was talking about, or you end up, you know, going to those hospitals and then being transferred. And as you transfer more and more patients from a rural hospital, then you have less and less revenue to sustain the services you already have. And this turns into a negative cycle where you have a lot of people leaving your community because the revenue's leaving your community because you have a higher transfer rate. Next slide. So this has a lot of effect on disparities in rural communities. And we see this in rural Georgia. You know, Georgia is an interesting place to work as a healthcare provider. You have cities like Atlanta that have great healthcare, certainly in certain areas. And then you move not too many miles outside of a city, and it's very, very rural. And oftentimes there's a lot of disparities, and we have some of the poorest outcomes in the nation when it comes to a lot of our chronic disease management. So the disparities are real. It is linked to the rural community hospital and their capabilities. And you have a lot higher incidence of poorly controlled disease, increase in delays in emergency treatment of conditions, delays in specialty care treatments. You have less coordinated care also, which has a major impact on your health care quality of life. And you also have higher morbidity and mortality, which is, you know, what we see in the statistics. Next slide. So our program is a rural community hospital focused telemedicine program. Next slide. We really are working to decrease that negative revenue cycle by helping rural hospitals over time increase their capabilities and keep more patients. And as they keep more patients, they have more revenue. And as they have more revenue and reinvest in themselves, they have even more equipment and then more capabilities. And over time, you have increased reputation, so you have more and more patients. And so it's a self-sustaining cycle of positive and not negative. Next slide. So our the way it's conceptualized, we have multiple parts to our network. We work anywhere with the hospitals, the rural hospitals, from triage to discharge. So we start in the ED, we take care of inpatients, and we take care of critical care patients if the hospital has a critical care unit. And we also provide education to support increasing complexity of care in the rural hospitals. So the way we kind of put this is our health system connecting with the rural hospitals so that they have an academic tie, they have a resource so they can help get that education and support. We really see this as a telemedicine ecosystem, and our goals are to decrease health disparity. That's where we start out. It's really a patient-focused benefit. What we're trying to do is keep rural patients in rural hospitals if possible. So if we can help that hospital take care of that patient, not transfer that patient, then that's going to lead to a lot of positive outcomes. If we can keep them there, then they'll have increased revenue, they'll have increased volume, so better financial viability, and I'll show you an example of that in a minute. We have if they exceed that rural hospital's capabilities, then we expedite their care. That's usually a transfer, but that doesn't necessarily mean that it comes to us. It could be to another hospital. And a lot of times it is. But we're helping them to identify that, yes, this really is a truly sick patient that's beyond your capabilities. Let's go on and make that as fast as we can to that service that they need. By a byproduct of this is we're decreasing unnecessary hospital transfers that helps those of us in cities. So, whether it's, here at AU Health or up at Emory, when we get a lot of people coming in from transfers that don't really need our services, it also slows us down. So this is a win for us too. It does lead to better coordinated care, and this one's a little harder to see, but when we return people back to their community, and I'll show you that in a second, we continue to follow along so that we have a continuity of care of trying to keep down their 30-day readmissions. And then again, you can't do this without supporting the rural hospitals with education. So we have that built in too. Next. So just a few pictures just to show you a little bit of the technology. We try and use really non-proprietary software. So we use a Cisco-based server that connects us through specific channels. They're HIPAA compliant channels to the rural hospital. We can tie in pretty much any device that has a digital signal, whether it's a video laryngoscope or an ultrasound monitors. We can tie them into the system. So it's almost like we're there, but it's really based on teleconferencing. Next. This is a relatively up-to-date list of all of our hospitals. We just added another one up in Jasper County that we're working on onboarding now, but we're spread across the state. Where we are in the state is fairly intentional. Coming out of the red dot, which is Augusta, going south towards Savannah, and then across the bottom part of our state, kind of like a reverse L, is some of the worst outcomes, health outcomes in the country, and also Georgia. And so those are the hospitals we're focusing in on trying to improve the care there. I'll point out Candler County Hospital, which is pretty much in the middle of all the blue. I don't have a pointer, but you can look for that. That one we're going to talk about specifically in just a second. It was the #2 hospital on the Georgia in Georgia to close in 2019. So you can imagine if you lost to healthcare right there, you would be about an hour and a half from Augusta, hour and a half from Augusta, hour and a half from Savannah. You're really kind of far away from other healthcare systems. Statesboro would be the closest place you could go. Next slide. So our program runs in stages or phases. We really start in the emergency department because that's where a lot of transfers, where you can impact the transfers, you can help identify or triage which ones are really kind of unnecessary, and you can expedite the ones that really are necessary. But really where we make our biggest improvement is on the inpatient side. So that's usually phase 2. So working on the inpatient or the critical care side to support those rural physicians, helping to fill that complex care gap. Phase 3 is where we're moving into returning patients back to their home county and their home hospital to help support their average daily census in the rural hospitals, but also gives us a place to offload patients and also a potential for us to do care coordination. And that's really phase 4 is where you're working into regional care coordination of these patients. Next slide. This is from last quarter, so we're even a little bit better now. We're almost at 3,000 patients over the last almost 3 years with nearly 10,000 encounters. What you can see is that our overall transfer rate has increased year over year from these rural hospitals. You would think that may be a negative, but in reality, what's happened is their case mix index and their complexity of care they're delivering in the rural hospitals has also increased. So as you can imagine, is they are keeping more and more complex patients there with more of them are coming to the rural hospitals. We are having to transfer some of those, but we are also keeping more of those there. And so we keep almost 75% to 80%, depending on the hospital, of the patients we see in their rural county hospitals. When they have an ICU, we can keep more, of course. But we don't always transfer to us. We transfer, 10 to 25% of our patients to other hospitals. So we're just a facilitator. We're just there in the boat working along with these rural hospitals. Next slide. This is just a few quotes from some of the hospitals we work with. One I want to point out is the bottom right corner, which is Candler County Hospital. So when we started working with them, they did two things. They started working with us on telemedicine, but they also brought in a group for their hospitalists that were committed to working with telemedicine. So with those two things, we went from having not too much cash on hand. I won't say exactly how much, but they were number 2 on the list of closure for Georgia. And we've increased their revenue greatly by helping keeping more patients there. And now they're quite viable. They're doing very well. We're working with Evans Memorial Hospital, which is down near Savannah and Claxton. They've developed their own ICU over this program so that they can keep more and more patients. And I think this is just a testament that, you know, with increased revenue, you can reinvest in your hospital and bring more services to rural counties because you have that revenue coming in. Next slide. And so why is this important in disaster preparedness? Well, there's a few reasons. You know, one of them is that as you have increased capabilities for complex care, you know, then when a disaster does happen, you have more equipment on hand, you have more up-to-date equipment, you have supplies, plus your staff is better trained in complex care. So there's the ability then that they can keep more of those patients and not transfer all of them to a higher level of care when a disaster happens. It also means that the EMS has more confidence in what they can do in their local community hospital. So sometimes it means that you're keeping more people in your rural county, but also that there's less time to treatment because they're not bypassing that hospital and moving on. The other thing is that because this is a daily, we're using telemedicine daily and connecting to these rural hospitals. The equipment, you know, is up and running. That's great. The people are trained in how to use the equipment, so it's usually pretty easy to turn it on and make sure everything's working. But they also know the process of getting somebody to come in and help with a complex patient. The other thing, which is easy to overlook, is that, you know, you have established relationships. So when you do have a disaster and you call in, you're seeing a familiar face on the other side. You're believing what they say when they say, "Hey, I understand you're in distress right now. We'll bring some help to you. We'll try and offload some of these patients, but we need to keep some there, and we'll back you up when we do that." So that's really important too. And so I think this increased connectivity with rural hospitals and academic centers, whether it's Emory or it's AU, is really important because it helps with regional disaster coordination. It certainly can help with surge management and helping to improve our capacities across the state when there is a major event. It really helps us understand the rural hospitals because we're working with them so frequently, what their capabilities are, at what point you would have to transfer a patient. So if you're taking care of patients there, you know what they can handle and what maybe too much for them. And then it also allows us to have that avenue for education and training, which is really important when it comes to disaster preparedness. And I think that's my last slide. One more, I think. So this is just our websites if you want to go look. And I sure appreciate being able to give y'all this presentation.
Hey everybody, I'm the anchor here, and I'm looking at the time, and I'm going to be efficient with my comments. And well, first, to introduce myself, I'm Alex Isakoff. I'm an emergency medicine and EMS physician at Emory University. I work clinically at Emory University Hospital with my colleagues, Drs. Ross and Carr. I am the principal investigator for the Southern Regional Disaster Response System. And really, I represent the executive committee today and other partners. Drs. Ross, Carr, Lyon are partners in this endeavor. This is a grant that has come to really a consortium or collaboration of institutions. Emory University, perhaps being prime, is receiving the grant, but wouldn't have been possible without our partnership and collaboration with colleagues at Augusta University Health System, or Wellstar MCG, the University of Georgia's Institute for Disaster Management, and the Georgia Department of Public Health, and other partners that you see listed here among the executive committee. With the time that I have, actually, I do want to say Doctors Lai and Ross and Carr really made my delivery of the punchline here quite easy. What they've described are systems that address a lot of issues in healthcare today. They're helping to address issues around inequity in healthcare access, challenges of delivery of care in rural settings, providing clinical subject matter expertise to areas that might otherwise have a challenge in accessing that, whether that's in the whether in the EMS system, the emergency department, or in a critical care setting. And these are day-to-day issues that need to be addressed, and each of them has presented a model, in many cases catalyzed by grant funding, but ultimately developing a business case for sustainability, which is critically important. As it relates to applications for managing the issues that would come from a mass casualty incident, from a chemical, biological, radiological, nuclear event, what you've just heard are means by which sustainable methods for providing clinical subject matter expertise and guidance for care of complex patients can be delivered in a sustainable way day to day. And the partnership with the Southern Regional Disaster Response System is to engage our partners that have these robust systems, sustainable systems, and work together to find ways to really pivot those capabilities to the needs of patients that would come after a mass casualty incident. I think everyone on the call would agree that the concept is a no-brainer, but making it happen, making it operational, making it functional takes effort. And so SRDRS, represented by a number of people on this call and many others, are looking for systems that have robust ability to provide clinical subject matter expertise, care for patients that are sustainable and can be pivoted to the needs of patients in a disaster, helping to improve our region's ability to manage a mass casualty incident. Next slide. So the Southern Regional Disaster Response System is funded by ASPR, the Administration for Strategic Preparedness and Response within the U.S. Department of Health and Human Services. And we are the fourth region in the Southeast, HHS Region 4, to be funded. Regions 1 and 7 were funded in 2018. Region 8 was funded in 2020. Next slide. Roughly, at a very high level, what we're trying to do is improve capacity for management of patients that would come as a result of a CBRNE incident, again, chemical, biological, radiological, explosive, nuclear, and increase access to clinical subject matter expertise, and do it in a way that, that complements programs and systems that are already in place. It's not a good investment to reinvent the wheel, and we're doing everything we can not to reinvent the wheel. Part of, again, how we want to complement existing systems is to partner with the health departments and their healthcare coalitions that have already been in place for many years. We want to identify centers of excellence within our region that are also, by chance, happen to be federally funded or state funded, that bring clinical subject matter expertise to the management of biothreats, or to the management of chemical injury, or to the management of radiological injury. And we do that, and we'll mention it in some slides coming down the road, through our natural partnerships with entities like the National Emerging Special Pathogens Training and Education Center, Regional Special Pathogens Treatment Centers, poison centers throughout the Southeast, and Radiation Injury Treatment Network hospitals. We're also working with any health system or state entity that has a capability for redistribution of patients and load balancing to prevent overload on any particular health system. And again, all in an effort to improve our capacities and capabilities for management of CBRNE casualties. Next slide, please. So regional partnerships are key for the SRDRS. The development or embracing concept of a medical operations coordination cell is critically important. The expansion of telemedicine systems, or the, again, embracing of telemedicine systems that are already proven, that have a reasonably sound business case and are sustainable and are functioning day to day, that can be pivoted to the needs of disaster casualties. And through this process, develop a repository of resources for frontline healthcare personnel that might have need to manage CBRNE incidents. Next slide, please. So at a very high level, we started in Georgia, but of course our scope, as you saw from the map, is the 8 states throughout the Southeast. We are partnering in part with a state-funded initiative called the Georgia Coordinating Center, which has as part of its mission to understand capabilities and capacities of hospitals in the state. This is an initiative that started in the Metro Atlanta area. And then by understanding what those capacities are, I help direct ambulances from scenes where they're picking up patients to go to a hospital that has capacity and capability for managing them. Next slide. Through colleagues that are leading work at the Georgia Poison Center and poison centers across the Southeast, our Associate Medical Director, Dr. Ziad Kazi, not on the call, leading this initiative to develop a collaborative among the 10 poison centers that are operating in the Southeast to ensure that there's a robust capacity to provide clinical subject matter expertise, for example, needed for management of chemical casualties or radiation injury casualties. Next slide, please. We're working to expand our engagement with hospitals that are designated within the radiation injury treatment network, again, to regionally better coordinate and develop dialogue around best practices, creating access to clinical subject matter expertise, and help to better manage patients that would come from a radiologic incident or a nuclear incident. Next slide, please. We in Region 4 have the privilege to have one of the first of 10 regional special pathogens treatment centers at Emory University Hospital, and within the last year, a second regional special pathogens treatment center designated by Department of Health and Human Services, ASPR, at UNC Chapel Hill to lead our biothreat capabilities and capacities, as well as our tie to the National Emerging Special Pathogens Training and Education Center. Next slide, please. So we talked a bit about being prepared for biothreats, radiation threats, nuclear threats, chemical threats. Of course, we have partners also among designated trauma centers, specialty care centers for the care of pediatric patients, dialogue with burn centers, all which will be important for managing patients that would come as a consequence of a CBRNE incident and improving our access to the clinical subject matter experts that can, in much the way that we've heard thus far, empower clinicians at local hospitals and other centers to care for patients that they might otherwise think need an immediate transfer. It's through access to these clinical subject matter experts and medical coordination cells and through telemedicine that we can likely improve our capability for secondary triage of patients, meaning once a patient has come to a hospital for care as a result of one of these incidents, we need to know who needs really among those to be transferred to a specialty care center, because we know that transport capacity and bed capacity is limited, and those decisions will be best informed by the appropriate clinical subject matter expert. Next slide, please. That's where I'll end with 1 minute before the hour. I'm going to stand down, and thanks for the opportunity to present.
Thank you so much, Dr. Isaacoff. Thank you, Dr. Carr. Thank you, Dr. Ross and Dr. Lyon, for this amazing presentation. I hope this was insightful to many of you looking to learn about telemedicine, emergency preparedness, and maybe how you can play a role and or what your organizations can do. If you submitted a question in the questions and answers box, please know that most of the questions have been answered. Being mindful of the time, there are 2 questions on here right now, so I'm just going to go ahead and pose these for you guys, and whoever wants to answer them can take a stab at it. Are you using digital devices such as stethoscopes, ophthalmoscopes, otoscopes, et cetera, for physician exams via telemedicine?
I can say if you're doing provider to provider telemedicine where you have a nurse or an APP on site, that's not as important. So in the back of an ambulance, the medic is the stethoscope and looking in the mouth and ears and things like that. Same thing in the observation unit. I find that whatever we can't do with the camera, the APP at the bedside can do. It's a different issue if you're doing direct to consumer, where you're seeing people at home.
Thank you. One more disclaimer before we end with the last question. Please note that thank you all for attending today. This webinar is recorded, so we will make sure that we post it on our Southeastern Telehealth Resource Center website and send out a link and be able to post that there for you guys. Final question. I think this is for Dr. Carr. I think it was around the transportation of vehicles, looking at the tele-EMS. The question is, who owns the ground transportation of vehicles across counties, and how do you coordinate payment and management of that equipment?
So great question. I think so all of our equipment so far has been funded by the grant. As long as we can justify that a county or an agency is located in a HRSA designated rural area, the grant will support the equipment. Now, the caveat is, of course, as far as sustainability, once that equipment infrastructure is there, we have to maintain our connectivity and our subscriptions to telehealth software. That's really where the sustainability and the financial viability piece comes in. So the multiple tiered sustainability plan is going to play more of a role as our grant funding runs out. So the goal is really to deploy as much equipment as possible under the grant funding. And then once the infrastructure is there, work on sustainability.
Thank you so much. Any final comments or thoughts from the group? Hearing none, thank you guys for joining today's The Pivotal Role of Telehealth and Disaster Response. We hope, again, this was beneficial to you all. Thank you again to our amazing panelists and speakers, Dr. Carr, Dr. Isaacoff, Dr. Lyon, and Dr. Ross. We look forward to hosting more of these in the future, and be on the lookout on the Southeast Telehealth Resource Center for additional upcoming webinars. Thank you all so much for your time, and have a wonderful day.
Thank you.
Thank you.